So let's get started. We will start the recording now, and we will start doing the benign endometrium. So we are done with the vulva and the cervix, and now we are going up, or we are moving up to the endometrium. We'll do the benign endometrium today, and then next time we'll go over the endometrial cancers and the endometrial tumors. So um, let's get started. Okay. So we'll talk today about the benign endometrium. The only tip that I want to give you before starting to talk about this endometrial thing and this benign endometrium is please don't make sure when you look at any picture or any virtual slide or anything for benign endometrium or for the endometrium, sometimes the endometrial glands catch your full attention because you are like distressed and you need to reach out a diagnosis right away. So you start jumping with your eyes and get the very close look only to the endometrial glands. Please make sure that you have a careful look on both endometrial glands and the endometrial stroma. Don't ignore the stroma because sometimes the clue or the keyword or the pathognomonic sign is in the stroma, not in the glands. So make sure you look at both in order to be good and in order to reach a diagnosis faster or quicker. So the first thing they need you to know for the boards and even for your practice is these regular endometrial curettings and these regular endometrial biopsies that we receive in our everyday sign out. So they need you to make sure they need to make sure that you are able to identify how the endometrium look like at the different phases of the menstrual cycle. Of course, we have two main phases of menstrual cycle. We have the proliferative phase for the endometrium cycle, which is the first half. Potentially, it's virtually the first half of the menstrual cycle, in which there is an estrogen effect on the endometrium, which have a proliferative effect or make the glands, the lining of the glands proliferate, and there is active mitosis, and there is this kind of proliferative phase. And then the second half of the endometrial cycle is the secretory phase, in which you have the effect of progesterone, which is the abundant hormone in the second half of the menstrual cycle. And this leads to secretions both in the endometrial gland, and even it leads to like edematous stroma. The stroma starts also accumulating some kind of secretions, and it become a little bit edematous. So you have secretions in the glands, so the glands get dilated and get tortuous, and the secretions start to appear in the glands at the different phases of the secretory phase. And then finally, you have the menstrual phase of the endometrium, in which the endometrium break down and it fall apart and comes down with the menstrual blood, and then it repeats itself over and over again. So these are the three phases that we need to make sure that we are able to identify by histology. Here's the first one, which is the proliferative phase. So how does the glands look like in a proliferative phase? First thing, you need to look at both glands and the stroma. So when you look here at the endometrial glands, you'll see that the glands are not dilated. They are relatively like circular, rounded. They're not dilated. This means that there's nothing filling them up. There's no secretions yet. Okay, so to confirm, you go high power on one of the glands And you see this pseudo-stratification of the cells. Like we say pseudo-stratification because it's not true stratification. Every cell is able to reach the basement membrane. However, they look as if they are stratified. So there is potentially, you might say there's two cell layer, but this is actually pseudo-stratification that you see here. And then you see the mitosis, the active mitosis. And sometimes you see irregular shaped mitosis. This means that these cells are actively proliferating and they are filling up or piling up in the lining of the endometrial gland. When you look at the stroma, here, the stroma doesn't look edematous. The stroma look relatively dense, but it's not like that much dense, not hyper dense, but it's dense. It's not like edematous stroma. So, but you see abundant stroma in between, which is not edematous. So dark blue, why dark blue? Because the cells are crowding up, piling up. So it's dark blue tubular glands. So this means that the glands are not dilated. And you have the abundant stroma in between the glands. However, there is pseudo-stratification. It's not true stratification, and you see the classic mitosis, as I mentioned. This is the proliferative phase, which extends from day 4 to day 14 of the menstrual cycle. Usually, this is not subdivided to any early proliferative or late proliferative, but secretory phase does. There is early secretory and late secretory. Early secretory is a board favorite for some reason. It's extremely boardable, abused in Q-banks. As you see, it's a 3-star diagnosis. I didn't see any Q-bank not asking about this thing, which is the early secretory phase. Here, the glands start to dilate. Here, the glands start to dilate. When the glands dilate, they become a little bit tortuous, as you can see here. So endometrial glands are getting tortuous. Oh, okay, tortuous. So this means that they are dilated. Possibly it's starting, the secretions are starting to accumulate there. Let's go high power. So you go high power and you look at the lining of the glands, you will see that there is secretions. Yes, it's true. Secretions are there, which is this clear vacuole. However, the secretions are still subnuclear, still at the base of the cell. It didn't reach the apex yet, because the secretions usually start to form in the base of the cells of the glands of the endometrium, and then it migrates towards the apex of the cell, and then it spills in the lumen of the endometrial glands. So this means that we are in the early phase of the secretion or early secretory phase. I love this metaphor. They say it looks like piano keys, and it does. It really looks like piano keys. So piano keys is a very, very important picture for your boards, in which there is an early secretion accumulating in the subnuclear area of the cells lining the endometrial glands. So subnuclear clear vacuoles. And this starts from day 17 to day 19 approximately. There is a phase which is called interval phase. They would never test you in this. And even if it comes in the daily practice, my attending told me an attending will call it proliferative and an attending will call it early secretory. And both of them are right. So you won't be tested and you won't encounter anyone calling an interval phase as a diagnosis for an endometrial biopsy, for example. But early secretory, no, you should be able to identify this. Then mid-secretory to late secretory. The mid-secretory also is not so boardable. However, you have the dilated glands, same thing. Glands are starting to, glands are dilated, tortuous, and the secretions are there at the apex, at the other side of the cell, at the apex, near the lumen. However, what you get tested in is the late secretory phase, in which the glands become so dilated to the point that they might look as if they are back to back, or as if they are very near to each other. See, due to the extensive gland dilatation, they become so near to each other. Like, look at this area. If you go high power at this area, you'll feel like these are back-to-back glands with minimal stroma in between. So please make sure to have the habit of training your eye. how the secretory endometrium differ from endometrial hyperplasia, for example, or endometrioid adenocarcinoma. It's impossible to call this endometrioid, but some people might get tricked and say, oh, this is endometrial hyperplasia. I see a lot of glands, back-to-back glands, a lot of glands, and the gland stroma ratio is 2:1. No, this is not 2:1 gland stroma ratio. If you honestly looking at this picture at low power, you might say that the gland to stroma ratio is like 1:1. Like they're nearly the same in terms of ratio. So the difference between the late secretory phase of the endometrium and the endometrial hyperplasia is just the gland to stroma ratio. Here the glands are very dilated, very tortuous, to the point that they say that they look like the sawtooth. They look like the sawtooth, and they're very condensated. They're very back to each other. And the secretions here is in the lumen, inside the lumen of the glands. See the secretion here is spilled in the lumen. It's already there in the lumen. And when you look at the stroma in any of the secretory phase of the endometrium, see that. Look at this stroma and make the habit of comparison. See, compare this area of the stroma to this area of the stroma. See, the stroma here is loose. It's edematous. However, the stroma here is tight. It's dense. So dense, tight stroma is proliferative. Loose, edematous stroma is secretory. Make sure you know the changes in the glands and the changes in the stroma, because sometimes the stroma confirm the diagnosis from the glands. So there we go. We have them proliferative, early secretory, and late secretory, which is the sawtooth and piano keys. Then the menstrual phase. In the menstrual phase, you have blood. Here's blood here. That's blood, bleeding, hemorrhage. You see that the endometrial biopsy is like full of hemorrhage, predominantly hemorrhage. And when you see endometrial glands or endometrial stroma, you feel like the glands are fragmented. See, like this gland. That's a fragmented gland. And you might see also inflammation, reactive inflammation, and some neutrophils. However, they are not there in this picture, honestly, but you might see neutrophils. Why neutrophils? Because this is actually necrotic endometrium. The endometrium that comes down in the menstrual phase is actually dead endometrium. So necrosis leads to reactive acute inflammation, and there's neutrophilic infiltration. So you might see neutrophils, not always. But if you see predominantly blood, stromal hemorrhage, very red appearing, and you might see some neutrophils, and you see some fragmented glands. Oh, this is menstrual phase. And it starts from day 1 to day 4. And then from day 4 to day 14 is proliferative again. And then 15, 16 is interval phase. 17 to 19 is early secretory. And then 20 to 29, I call it like 20 to 29 is late secretory. And that's it. Okay, so these are the different phases of the benign endometrium in response to menstrual cycle and endometrial cycle. Atrophic endometrium is also very common. And you might see that in a spot diagnosis question. And you see it extensively in our daily practice and in our biopsy sign-outs. So atrophic endometrium happen, of course, in postmenopausal women, because in postmenopause, you don't have any progesterone, you have some estrogen, which is very low estrogen level. And this, of course, leads to genital tract atrophy, including atrophy in the endometrial lining. So when you look at the endometrial lining, so you have a low power keyword and a high power keyword. The low power keyword is when you see cysts. See? That like cystically dilated endometrial glands. This, they call it the Swiss cheese. It looks like the Swiss cheese. So Swiss cheese, cystic endometrial glands. This is the low power keyword. High power keyword, you will see single lining. And the lining nearly doesn't have any cytoplasm. Like if you look at these cells, is there any cytoplasm there? No, it's like no cytoplasm. It's as if there's a single layer of nuclei, like beside each other, and they are making this like paper clips. They're falling apart or falling down and making this like curves, which look like a paper clip. So they are making this paper clips. Single layer atrophic cells. That's atrophic endometrium. So see, it's very thin. Why thin? Because it's just a single layer, flattened, atrophic epithelium. No mitosis is seen. And you see that the glands are very widely spaced. They are wide from each other. And the stroma is very collagenized. See how pink the stroma here. See how pink the stroma look like. This is what we call collagenized stroma. And on biopsy, you might see some scant strips of surface epithelium with making these paper clips. And they are very atrophic. That's what we call atrophic endometrium. Atrophic endometrium is also benign. This is very common. Very common, this one. Very common in our practice. Not common in the board question, in the board Q banks though. But it's very common in our questions, in our daily practice. You know why? Because a lot of females who do like endometrial biopsies, they're usually either they are on oral contraceptives or they're having like, let's say, a medicated IUD in place. You have an intrauterine device which produces progesterone, or you're taking oral contraceptive pills, which is progestin only pills. This is what's caused by progestin, exposure to progestin. Progestin, guys, leads to this kind of decidualization of the stroma. See the stroma here? The stroma cells are now not spindle anymore. See, there is no spindle stromal cells. The stromal cells are getting very plumpy. They are becoming very plump epithelioid. They become like an epithelial cell, see? That's what we call epithelioid or large epithelioid stromal cells. Sheets of large epithelioid cells. The cells have pink cytoplasm and some kind of cytoplasmic clearing. The cytoplasm is very pale pink. Large epithelioid. This is what we call decidualized stroma. However, what does the progesterone do to the glands? Anybody know? What does the progesterone do to the glands, the endometrial glands?
Maintain them, I guess.
They maintain them. Not really. They lead actually to endometrial glandular atrophy. Actually, they might lead to some kind of glandular atrophy. And this is what you will see later. See, in the dysfunctional endometrium, see? I will show it to you. This is actually one of the important things, the IUD effect. Yes, here it's in the very last page. Here, oral contraceptive effect. This is the exact same thing. The exact same picture is here. See this decidualized stroma?
Yeah, I have a question. Is it the progestin, because the progestin has a androgenic effect as well? It's not like completely progesterone. It's
No. You know, because one of the physiological effects of progesterone is being anti-estrogen.
oh, okay.
Progesterone, if you read progesterone physiology, you will see that one of the key things of progesterone is that it acts as an anti-estrogen. And that's why it leads to a small atrophic glands. See the glands are very small, atrophic.
Mhm.
However, the stroma is full of secretions, and the cells in the stroma are getting really epithelioid because of the accumulation of the secretion. You got it? That's how a decidualized endometrium look like. So that's why that tells you how important it is to look at the stroma. Don't only look at the glands, because in a case like this, you keep looking at the glands and you're seeing nothing. Like, what the heck is these glands? The glands are very like benign looking, very circular. Is it proliferative endometrium? But I don't see any pseudostratification. I don't see any mitosis. I don't see, because this is because you're focusing on the glands. Come on, man, look at the stroma. If you look at the stroma, you will see the decidualized stroma, or the large epithelioid cells. This means that you're looking at a decidualized endometrium, okay? So the decidualization, then it's caused by progestin, and it leads to large epithelioid cells, and the glands become very widely spaced and atrophic. This is very important. Atrophic because the progesterone acts as an anti-estrogen, unfortunately. Arias-Stella reaction, we kind of went through this when we were talking about the cervix yesterday, right? We mentioned that this is related to pregnancy due to pregnancy hormone, which is the HCG, the human chorionic gonadotropin. And that's why Arias-Stella reaction not only happened in pregnancy, but it happened in gestational trophoblastic diseases. Because in case of gestational trophoblastic disease like hydatid cyst, molar pregnancy, this kind of molar pregnancy, and the complete mole and partial mole, they lead also to elevated HCG, and this might lead to Arias-Stella reaction as well. So Arias-Stella reaction is when you see, I always say, whorls of dark cells, or whorls of cells with dark enlarged nucleus, which look really ugly. Honestly, if you don't put this in the back of your mind, you might end up saying that this is cancer. No way. So, and which type of cancer these cells might trick you with? What do you think? What do you think?
Clear cell?
Clear cell, yeah, exactly. It's really, see,
Hobnail.
and that's why they're saying unlike clear cell carcinoma. That's why he's saying that, because most of the people get tricked and just overdiagnose this as clear cell carcinoma. And that's why in any case you're feeling that you're looking at clear cell carcinoma, look at the age of the patient and make sure to throw some immunos just in case. What were the immunos that we said yesterday about clear cell? Anybody remember?
Napsin,
Yeah, napsin A.
and then HNB something one.
Yeah, HNF1 beta.
And
Yeah, HNF1 beta. HNF1 beta and napsin A. These two, well, they are positive in clear cell, negative in Arias-Stella. And there is also, he's saying here it has low Ki67. Arias-Stella has low Ki67, but clear cell carcinoma has high Ki67. Also, Arias-Stella happen more in reproductive age females. Clear cell carcinoma happen in old age postmenopausal females. So when you look at an endometrium and see, oh, I see clear cell carcinoma, back up a little bit, look at the age, make sure you throw some immunos to confirm. Because it might be like Arias-Stella reaction or pregnancy-associated change, pregnancy change. So see, it's enlarged pleomorphic hyperchromatic nuclei. The cells have enlarged pleomorphic hyperchromatic nuclei. It can mimic malignancy, but it's actually benign. The key malignancy which it really mimics is the clear cell carcinoma. Dysfunctional endometrium. What's the meaning of dysfunctional endometrium? Dysfunctional endometrium is the endometrium that exists in females suffering from dysfunctional uterine bleeding. Dysfunctional uterine bleeding. What's dysfunctional uterine bleeding? Can anybody like give me an idea? What's the meaning of dysfunctional uterine bleeding?
Like menorrhagia and metrorrhagia and all these old terms.
Yeah. But the key thing is what a disorder in the hormones of the menstrual cycle. So,
Yeah.
and the key disorder that happen in most of the females with dysfunctional uterine bleeding is anovulation. Anovulation. So no ovulation happened. So if no ovulation happened, this means the corpus luteum didn't form. And if corpus luteum didn't form, this means that no progesterone. It would be only estrogen driving the whole thing, driving the whole cycle. That's what we call unopposed estrogen effect. Okay? And the estrogen keep making the cells proliferate until the blood supply is not enough. So still cells of the stroma and cells of the endometrial gland start breaking down and going down, leading to some bleeding, which go down for one day and then it stops again. And endometrium start building up another crowd of cells, which then also fall apart and break down and make another day of hemorrhage. So that's why the key manifestation of dysfunctional uterine bleeding is irregular bleeding, breakthrough bleeding. The menstrual cycle is not happening in a regular pattern anymore. Well, the bleeding doesn't occur every like 28 days, 26 days. No, it's every like 3-4 days I have some blood coming down. So I'm sick of that. I can't live like this. That's how dysfunctional uterine bleeding is. So this is mainly happening due to anovulatory cycles. So no progesterone. So actually, so we are having a tonic estrogen effect. Another disease which is very closely related to this kind of dysfunctional endometrium is the PCO, polycystic ovarian syndrome, because in PCO there is unruptured follicles which accumulate in the ovary and form cysts. That's why they call it PCO, polycystic ovarian syndrome. Here is how the endometrium looks like. When you see these blue balls, that's a key word actually. Blue balls, here it is. Blue stromal balls, which are like floating in blood, floating in hemorrhage. This is stromal breakdown. The stroma is breaking down and falling apart. That's the blue cannonballs. Please remember this. These are like tight aggregates of collapsed and condensed stroma, which break down and fall apart in lakes of blood, in lakes of hemorrhage. That's what we call glandular and stromal breakdown. So you would say dysfunctional endometrium with glandular and stromal breakdown. Next line, negative for malignancy. That's how it's signed out classically. There's also a kind of dysfunctional endometrium called disordered proliferative endometrium. Disordered proliferative endometrium when you see a mix. What do I mean by a mix? A mix means you see cystically dilated glands, right? Yeah, these glands look very irregular. See? Oh, sorry. These glands look irregular, dilated. Well, dilated. Let's go high power, man. Might be full of secretions, and you go high power, you see proliferative pattern. You don't see any secretions in the lining of the glands. You see pseudostratification. You sometimes see mitosis. It's as if you're seeing proliferative endometrium, but the glands are cystically dilated. So it's taken from both. It's taking one of the secretory criteria, which is the cystically dilated gland. And when you go high power, you see proliferative endometrium or proliferative endometrial lining of the endometrial gland. Some endometrial glands also look purely proliferative here. So it's as if you're having a kind of hormonal problem. This endometrium is not properly responding to a proper hormonal pattern. So it looks like there is estrogen, some progesterone that might come and take place, but the estrogen is driving the whole thing to the point that you see some endometrial glands which look very proliferative, and some other endometrial glands that try to become secretory, but still their lining look proliferative. That's when we say disordered proliferative endometrium. And these kind of endometrium, or this kind of endometrium usually have abundant stroma. That's to differentiate it from endometrial hyperplasia, because sometimes someone might get tricked. Oh, this is normal endometrium and this is hyperplasia. So that's the area of hyperplasia, and that's the area of normal endometrium. Nope, this is incorrect. Why? Because you need to look at the stroma. The gland to stroma ratio here is not 2:1. That's 1:1. It's not 2:1. We'll see how endometrial hyperplasia look like when we come, or when we reach the malignant endometrium. Okay, so let's double check. So we had proliferative endometrium, rounded glands, pseudostratification with mitosis. Okay, and then we had secretory endometrium, which has early secretory, late secretory. Any secretory endometrium would have cystically dilated glands or dilated endometrial glands with secretions. The secretions could be subnuclear piano keys in early secretory and luminal towards the lumen or inside the lumen in late secretory. And in any secretory endometrium, when you look at the stroma, you see stromal loose, the stroma is loose and edematous. Okay? What if you look at the endometrium and you see bland-looking circular glands which are very widely spaced from each other, and you see epithelioid change in the stroma with epithelioid stromal cells and pink cytoplasm with a little bit of pale pink cytoplasm. So what do you call this? What do we call this? Anybody remember? Yes.
Decidualization.
Yes, it's decidualized endometrium. It's decidualized endometrium. And this is due to the effect of progestin. It's either progestin OCPs or progestin IUD. Okay, and then we talked about the dysfunctional endometrium, dysfunctional uterine bleeding, in which you might see glandular and stromal breakdown, blue balls in lakes of blood, or you might see this disordered proliferative endometrium, which you see some endometrial glands which look like proliferative glands, rounded, not dilated, pseudostratification with mitosis, but others look like dilated, like the secretory, but when you go high power, you see that the lining is actually proliferative. There is still abundant stroma, so it's not endometrial hyperplasia. That's what we call it. That's what we call disordered proliferative endometrium. Okay. Adenomyosis, endometriosis, very easy diagnosis. And one of the classic pictures that you will see in your boards and in all the Q banks, 3 stars diagnosis and easy diagnosis, honestly. Adenomyosis is much easier to diagnose because they will tell you that this is like an area of myometrium, and they will give you this picture. Well, myometrium, okay, so I see endometrial glands here in the myometrium, and the blue area surrounding these endometrial glands is actually the endometrial stroma. So I see endometrial stroma, endometrial glands in the myometrium, that's adenomyosis. And if I see endometrial glands and endometrial stroma anywhere in the body outside the uterus, it's endometriosis. You might even, this endometrium might even bleed every month with the menstrual cycle, and macrophages might come to eat this blood, and you might end up having some hemosiderin-laden macrophages like this one. You see it? These ones. These are hemosiderin-laden macrophage, which had this brownish hemosiderin because of digested blood. Hemosiderin-laden macrophage. The question here, the classic questions that are asked by the attendings. It's not really asked in the boards, but it's asked by the attendings. Is hemosiderin-laden macrophages enough to call a diagnosis of endometriosis? Yes or no? If you see an area and the clinician or the surgeon the gynecologist, he's sure that this is endometrial implant. And he gives you a biopsy and say, rule out endometriosis. And he calls you, I'm sure this is endometriosis, blah, 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 blah. And then you look under the microscope and you see only hemosiderin-laden macrophage or macrophage. You didn't see anything else. Is it enough to call it endometriosis? So what do you do if it's not enough? What do you do? Hike gave me a good a call, which is we need to do CD10. Hike, can you unmute yourself and tell me what does CD10 highlight? CD10, what does CD10 highlight?
I think it highlights the stroma, right?
Yes, it highlights the endometrial stroma. If there is no endometrial stroma there, so what's the next step you can do? Do you say negative for endometriosis right away, or you do something else?
Pax 8? I don't know.
Hmm?
Pax 8?
Pax 8. And nope.
I don't know.
Yeah,
Yeah.
yeah. What
Maybe
you can.
maybe you do it deeper.
Yeah, good job. Deeper levels. That's what the attending need to hear, you know? He's telling, oh, I don't see enough evidence. What do you think, Abdurrahman? What do you think we need to do here? Oh, well, maybe we can do deeper levels. He will get so happy. Okay, yeah? Yeah, we do some deeper levels because the deeper levels might actually catch the endometrial glands, or you might see endometrial glands, endometrial stroma in the deeper levels. If you see in the deeper levels, you see hemosiderin-laden macrophage and some areas of spindle which might be endometrial stroma. Then I did what Hayek recommended. I did CD10, and the CD10 is highlighting that thing. Is that enough to say this is endometriosis?
I guess yes.
Yes. 2 out of 3 is enough. So you have hemosiderin-laden macrophage, endometrial stroma, endometrial glands. You need to see 2 out of 3. And if the only 2 you see are hemosiderin-laden macrophage and stroma, you need to make sure that this is actually endometrial stroma, not just the stroma of the connective tissue of the tissue that you're looking at. So you need to do CD10 to make sure that this is actually endometrial stroma. Okay? So you got it? That's for practice. That's not for the boards. So in endometriosis, we have endometrial glands and endometrial stroma causing some kind of pain with menstrual cycle. That's what we call dysmenorrhea. Endometrial glands can be highlighted by ER, and endometrial stroma can be highlighted by CD10. In endometriosis, you might see hemosiderin-laden macrophage in the area of suspected endometriosis. The other trick in adenomyosis is this depth enough to call it adenomyosis, or are these just deeply seated endometrial glands? What's the cutoff? A 4x field. A 4x microscopic field. There should be a 4x field distance between the focus of adenomyosis and the surface endometrium to call this deep enough, to make these qualify as being deep enough to call it as adenomyosis. See, he's highlighting this 4x field. And adenomyosis, as we all know, is endometrial glands and stroma in the myometrium. And we need a 4x field from the surface to call it adenomyosis. Make sure you remember this. It was asked like nearly 3 times in Path Dojo, one of the Q banks for the boards. They love this fact. I don't know, but it was not asked in any other Q bank. But it looks like the authors of Path Dojo, they love this thing. They love this information. It's associated with clear cell and endometrioid adenocarcinoma, the endometriosis, adenomyosis. It's highly associated with clear cell and endometrioid adenocarcinoma, to the point that sometimes we have endometrioid adenocarcinoma involving the endometriosis foci or involving the adenomyosis foci. So make sure you add this information to your current notes. I will send the modified notes, of course, on the Telegram group. Then, after endometriosis, we have the endometritis. The only thing that you need to memorize for your boards, chronic endometritis. Please, have the habit of identifying plasma cells. You need to have a good eye to be able to identify plasma cells. Can anybody tell me what are the criteria of a cell to be called as plasma cell?
Eccentric nuclei, cloak face chromatin, and the nuclear huff.
Oh yeah, good job. These things should be like, yeah, these things should be very, very, very easy for you to remember, especially when it comes you become PGY2, PGY3. You have to know this. That's eccentric nucleus, and the eccentric nucleus look like a clock face, or sometimes they say cartwheel nucleus, and there is this nuclear or some kind of a pale area around the nucleus. That's what we call the perinuclear half, or sometimes they call it perinuclear halo, but they hate this in hempath. A hematopathologist would hate you to call this perinuclear halo. It's not a halo. I don't know why they get like really nervous. It looks like a halo, man, but you know this very
It doesn't look like a halo. And I want to go to hempath, so it's a huff.
Yeah, so make sure you don't say perinuclear halo there, otherwise they get so like nervous. I don't know why. So and they might ask you why this perinuclear half. What is this? What actually it is? Does anybody know what this
I
is?
don't remember, but I'm just gonna guess it's Golgi or something.
It's Golgi. It is like Golgi because this cell is producing antibodies. Antibodies are proteins, and proteins need packing in the Golgi apparatus to be secreted, right? So it has abundant Golgi. That's why they have this perinuclear half. So presence of plasma cells. That's the key word for chronic endometritis. Let's say that's what my attending used to do. Our GYN idol is Dr. Han. She's our attending. So if the clinician, oh, I'm sure this is a chronic endometritis case, and you're not really convinced. Yeah, she had an IUD, she had a copper IUD, and she's suffering, she's having pain, and blah blah blah. So I'm sure this is chronic endometritis. So she say she used to say, let's throw CD138. CD138 is actually a stain for plasma cells. Maybe we're missing some plasma cells here or there, and then we can call it a chronic endometritis because we'll see that the CD138 is highlighting the plasma cells, so it's fine. But sometimes she always say, please don't overuse this CD138. Otherwise, you will see 1 or 2 or 3 highlighted cells by CD138, and you will overcall chronic endometritis in all the endometrial biopsies you have. So don't regularly use CD138, and this is confirmed here in Kirk notes. See, using CD138 to diagnose chronic endometritis is controversial and may lead to overdiagnosis. So try to rely more on morphology, but when you have like a headache because of a clinician who's just standing behind your shoulder and just like bugging you, you might think about throwing CD138 just in case. There's plasma cells, of course, chronic inflammation. This means that you will have lymphocytes. You might have some reactive cells in the stroma, reactive spindle cells in the stroma, and sometimes they are swirling around these plasma cells and making this kind of swirls or swirling pattern. Not important. The most important thing is making sure that you identify plasma cells. Chronic endometritis is highly associated with chronic irritation due to abortion, maybe recent abortion, use of IUD, which is usually copper IUD, and of course, genital tract infection by like chlamydia, gonorrhea, these kind of things. And it's sometimes associated with salpingitis and pelvic inflammatory disease in some cases. That's chronic endometritis. Okay. We have also acute endometritis. Acute endometritis is not so high yield. However, you will see neutrophil aggregates inside endometrial glands forming a like abscess, microabscess, glandular microabscess. So the acute inflammation and acute inflammatory cells, neutrophils, forming aggregates inside the endometrial glands, forming some kind of microabscess. When does acute endometritis happen? It usually happens either postpartum, in case of there is postpartum fever, postpartum sepsis, and post-abortion sometimes, postpartum, post-abortion. The other types of endometritis, read, not boardable, and not fairly common in clinical practice and in our daily sign-outs, but I saw this one time, xanthogranulomatous endometritis. It looks like xanthogranulomatous pyelonephritis, the same thing. What's the scheme for anything that in pathology that you call xanthogranulomatous? Anybody can tell me? Like when I say xanthogranulomatous anywhere, xanthogranulomatous pyelonephritis, xanthogranulomatous endometritis, xanthogranulomatous anything, what do you see? We always see what? Foamy macrophage. Foamy macrophages. So the sheets of macrophage with foamy cytoplasm and some kind of associated chronic inflammatory cells like lymphocytes here and there, plasma cells here and there, neutrophils sometimes, but here is the keyword. See, this is the pathognomonic thing, the foamy macrophage. Here it is, foamy macrophage. It usually happens, and these are the lymphocytes, by the way. I can't see any plasma cell here in this field. It happens usually in the old age, postmenopausal women, especially those with cervical stenosis, those with stenosed cervix. This happens, xanthogranulomatous endometritis. Oral contraceptive effect, which we call the metaplastic effect or other changes / metaplastic effects. This is decidualization change or decidualized endometrium, because we see this epithelioid stromal cells with abundant clear pink or light pink cytoplasm and widely spaced atrophic endometrial glands. Make sure you know that. Remember this. This is also important. I don't know, somehow some things are like very like it make you look very bad when you miss it, especially when you are PGY3 or like a resident who's advanced in his training. So the attending, how come you miss that? How can you miss such a thing? It's the squamous metaplasia of endometrial gland. So you see squamous cells inside the endometrial gland. So like this one, see, like this is an endometrial gland with a high power, and you see these nests. That's a nest of squamous cell. How do we know that these are squamous cells? Anybody can tell me, how do you identify squamous cells on histology?
Like a morphology?
Yeah, like a morphology, but not like a advanced histology morphology. You don't have to be so like philosophical in the description. Just tell me, what do you rely on when you look under the microscope and tell these are squamous cells?
Ovoid nuclei, ample cytoplasm, and clear cell borders.
Clear cell. This is the key thing. The last thing that you said is very good, very good. Like these like cell borders. That they look very cohesive, but still there is borders between the cells, because always the squamous cells, they attach together by these like kind of tight junctions. So you will see that there is like intercellular bridging or intercellular borders. And you mentioned like rounded to ovoid polyhedral nuclei and pink cytoplasm, and the cells are usually cohesive, forming a nest with cell borders which are like tightly packed or attached to each other. So here, solid nests of bland immature epithelium inside the endometrial glands, not endometrioid. That's a mistake. It's inside the endometrial glands. They are usually epithelioid, and they might have some necrosis, so don't get tricked and call it cancer. And the interesting thing is that metaplastic squamous cells in the endometrium doesn't have an immunophenotype which look like a squamous. It's negative for P63, which is a classic squamous cell marker. It's actually negative for P63, and they are positive for CDX2 and SADB2, which is actually like some kind of colonic source. But so they have a funny immunohistochemistry. So don't throw squamous stains and expect that these squamous cells is gonna light up. Nope. Metaplasia means irritation. Irritation means cancer. So please have this rule in your mind that when you see squamous metaplasia in endometrial glands, please suspect that there is a nearby cancer somewhere. Might be associated cancer, and it was not biopsied. And might be the patient is very lucky and she doesn't have any cancer yet, but she's almost there. And just document that in your sign out report, that when you see squamous metaplasia, that's why they hate, attendings hate when you miss it, because that's a pre-malignant sign, or even a sign that there is a concurrent malignancy going on. So you have to document this in your diagnosis, like this is, let's say, blah, 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 endometrium, whatever you see, proliferative, whatever. And then you say with squamous metaplasia or with prominent squamous metaplasia of endometrial glands, and C note. And then you say the note, in the note you say that this is the squamous metaplasia of endometrial gland could be a sign of concurrent or subsequent risk of cancer. You are telling them that you might have biopsied the wrong location and there might be a cancer somewhere else, or this patient is gonna go over to cancer at any time. So just consult with her. Maybe she would rather remove the whole thing and just take this headache off. Some other types of metaplasia might have mucinous metaplasia, not very high yield. You won't see it that much, but mucinous metaplasia, when you see columnar cells with apical mucin, it's like when you see endocervical glands. The problem with mucinous metaplasia or mucinous change is sometimes we have actually endometrial endocervical glands in the endometrial biopsy or in the endometrial curettage. So we are not really sure if these are actually metaplastic endometrial glands, or is it just endocervical glands which are there in the biopsy or in the curettage. You cannot really differentiate between them, and you don't have to. And that's why mucinous metaplasia never come in the boards. Because how we will know that this is mucinous metaplasia and not endocervical glands? However, there are some criteria that you can apply, but just don't bother about it. Also, this papillary syncytial change or papillary metaplasia or hobnail metaplasia, micropapillary or papillary metaplasia, you will see some kind of odd endometrial change with papillary structures or papillary architecture. And sometimes you will see this micropapillary areas. What I mean by micropapillary is the cells are like as if they are detaching or falling apart from the surface. That's the micropapillary pattern. All of this is not malignant. Imagine, although the cells look really ugly here, the cells look really pleomorphic here. However, they can mimic carcinoma, especially serous carcinoma. And that's why you need to do Ki67 and maybe P16, P53. And I will talk about this again when I talk about the serous carcinoma. So don't bother learning them right now. I will put it in the differential of serous carcinoma later. The other thing that I need you to know, is tubal metaplasia. Tubal metaplasia, the same thing, like what happens in the cervix might happen also in the endometrium. The key in the tubal metaplasia is what? Anybody remember from the cervix session yesterday?
Cilia.
Yeah, cilia. The presence of apical cilia. So apical cilia is the only thing that you rely on to diagnose tubal metaplasia. See, ciliated cells in the surface epithelium, which resemble fallopian tube lining. Hobnail change. hobnail change, when you see these hobnail cells, this is usually endometrial polyp which underwent infarction. It's like they always say it's highly likely to be an infarcted or ischemic polyp, infarcted endometrial polyp. That's why you're seeing this hobnail cell, because some other cells died and some other cells did not. So you see the cells are plumpy with spaces in between like hobnails. And this is actually a polyp which has like ischemia/infarction. What I would recommend in benign endometrium is focusing on the physiological endometrial phases, the proliferative, early secretory, late secretory, and you need also to make sure you can clearly identify the glandular and stromal breakdown. I'm sure what I'm saying right now, you won't have a question in the boards outside these. So the physiological phases of the endometrium, proliferative, early secretory, late secretory. The glandular and stromal breakdown in dysfunctional uterine bleeding, and the decidualized endometrium in case you have an IUD or progestin-only oral contraceptives, the widely spaced gland, atrophic glands, and these things. The squamous metaplasia of endometrial glands and the tubal metaplasia. And in cytology, you can get Arias-Stella. In cytology, you might get Arias-Stella reaction. Myometrium or endometrium in the myometrium, endometriosis, adenomyosis. But I'm not worried about this. It's easy. Everyone can really identify it on pictures or on images. Okay. Let's now go to the worksheet part or the practice part. Okay. Spot diagnose each of the following. So let's go by order. Abdurrahman, go first.
Okay.
What is this?
Proliferative endometrium.
Yeah, what are the criteria that you applied?
The stroma look busy, not edematous. The glands, stratified cells, and some mitosis.
Yes,
And it's not so busy with glands.
that's classic proliferative endometrium. The only thing that I'm telling you about, don't really get tricked by these like surface thing and call this secretions. Please don't trick your eye like Abdurrahman did. He looked at the cells first. He saw that there is pseudostratification, and he saw the mitosis here, and he saw the busy stroma. That's it, done deal. Don't hesitate yourself and start going back and forth. This is proliferative endometrium. Aliyat, what about this one?
Secretory phase.
Secretory endometrium. Which
Yes.
stage?
Early secretory phase.
Early secretory. Why?
Because the gland isn't like dilated enough, and the secretion in the like piano something.
Yeah, piano keys. The
Piano keys. Yes.
So if you relied only on piano keys, tell me piano keys.
Okay.
You know, okay, everyone loves science, you know, and I know that the attendings love this like sophisticated description. No, please describe, be descriptive. But what I need to make sure from these sessions, well, I will hit this well in the boards. Once you subspecialize, you'll be able to be good and you'll be able to like have this sophisticated description. But I will tell you, the sophisticated description is you have actually here dilated glands. You missed that, Alia. You said there is no dilate. No, the glands here are dilated actually because of this. See these secretions? There they are dilating these glands. And you have these secretions, which we call subnuclear secretions. The subnuclear secretions make the epithelium look like piano keys. What about the stroma? In the stroma, we have
Loose stroma.
yes,
Edematous.
loose edematous stroma. Good job. That's what we see in secretory phase. Then Hiba. Heba, what do you think about this one? That's a tricky one.
Maybe late secretary.
Late secret. Anybody has a different opinion?
Are these fragmented glands?
Fragmented glands. Another push?
Are these Arias-Stella? I don't know.
Well, but Arias-Stella must look this like irregular. They are not irregular. They still look like glands. But these glands they looks like there is but you are getting there. Looks like there is abnormal
plump.
cells here in the glands.
Like decidualization.
Decidua?
Decidualization. I will mark
Ah,
I will mark an area. No, I will mark an area and you will make it. You will make it. When I mark this area, you make. What do you see?
famous.
Look at these 3 cells. What do you see in the borders between these cells?
Famous.
Yeah, that's squamous metaplasia. That's squamous metaplasia. So I know this is really tricky, and this is like a really tricky picture, but you see these rounded polyhedral nuclei?
Yeah.
Some nuclei are rounded, some nuclei are polyhedral, but I always rely on these intercellular borders. They look like the squamous cells of the skin, like the skin squamous cells. They have these intercellular borders, tight borders. That's squamous metaplasia of endometrial glands. Muhammad?
But, this looks like well, I don't know. It looks like secretory again. I see
Yes,
the
early secretary.
subnuclear.
Why not? Yeah,
yeah.
I'm trying to go back and forth. So that's why I'm like.
Yeah, it's
So
like
this looks.
subnuclear loose stroma. Yeah, some I see here in the glands a bit some like secretion in the center.
Yes, so some
They're very
luminal,
folded together. Yeah, in a
luminal
way.
secretion, dilated glands, and subnuclear secretion and loose stroma with secretion. So this is early secretory endometrium. Okay. Siham, what do you think about this?
Okay, this looks like the blue cannon.
Yes, blue
Blue, yeah, so it's
ball.
glandular and stroma break
Yeah, the
down.
blue balls, the blue cannonballs. The blue cannonballs, and see, these are blue balls floating in blood. See the blood in the background? So blue balls floating in blood. So this is glandular and stromal breakdown,
Breakdown.
which
Yes.
happen in dysfunctional uterine bleeding or dysfunctional endometrium, right?
Yes.
Okay. I try to be as benign as possible. So I highlighted some cells here. So Abdurrahman, again, we are going back to Abdurrahman.
Well, I don't trust it. I demand a higher power view to see the half. No, it's plasma cells.
So you should like say, well, thank you, Muhammad, for highlighting the diagnosis for me. But
Yeah.
see, I'm telling you how much the plasma cells might be very scant. They might be very scattered. So you have to look carefully. And that's why I recommend, I really recommend in any case with endometrial biopsy, open the history. Open the history in every case. Sometimes you get a lot of endometrial biopsies, I understand, or I know. So you might like, let's look at this because most of them are benign. We will focus on the malignant. But when you open the history and look if the patient has IUD in place, if the patient is having IUD, it's either a copper IUD, so you'll be looking for chronic endometritis, or it's a Mirena IUD or progestin IUD, so you will start looking for decidualization, you know? So this history helps a lot. So that's why I'm saying how bland it might look. That's really bad. Alia, what do you think about this?
Estrogenic phase,
What? Again?
proliferative phase.
Proliferative phase. That's you know what? That's a good mistake. It's a mistake, but I appreciate it. That's what I
Or
was.
atrophic something, I don't know.
But
Atrophic
you know
in the
why? Because you focused on the glands.
yeah.
Focused on the glands, and you see the glands are not dilated. Yeah, this is proliferative. But let's say we went high power, we didn't see any pseudostratification, we didn't see any mitosis, we didn't see anything.
Oh
They're
yeah.
actually atrophic, widely spaced
Yes.
glands. So what do you need to look at right now?
The stroma.
You look at the stroma. So what's there in the stroma here? Is this stroma look spindle?
No. Epithelioid.
It looks epithelioid. The cells look a little bit plumpy. They look a little bit fat. They look epithelioid. So that's what we call
Decidualization.
decidualization or decidualized stroma. So
Yes.
decidualization, this happened in either progestin OCPs or IUDs secreting progesterone. The progesterone acts as an anti-estrogen, so it inhibits the estrogen effect on the on the endometrial glands. This leads to endometrial glandular atrophy and white spacing. And the progesterone has a secretory effect on the stroma. So this leads to this decidualization change in the stroma, because it actually, the progesterone, what it does is it maintains the pregnancy, right? So the environment around the baby should be full of secretions and full of nutrients. That's what happened in the stroma here. Okay.
Question.
Yeah. Yes.
How do you differentiate between atrophic versus inactive, or is it the same thing?
It's the same.
Interchangeable.
Yeah.
It's the same. Okay.
Atrophic is the same as inactive, and that's a good thing also. Muhammad, you see this? Can you see that? See this surface epithelium, or this surface, like it looks atrophic, right?
Yes.
It looks atrophic because we see this monolayer of nuclei with very scant cytoplasm in place. That's how atrophic endometrial glands look like. Who's next? I think it's Heba, right? Heba is next, or you already?
Yeah, maybe.
Yeah. Okay. What do you think about this?
Let's see. I see some like hobnailing.
You see some hobnailing. Okay. And see the high power of the cells?
Yeah, like foamy maybe foamy.
Benign endometrium is very tough. I know, I understand, but it's one of the,
Arias-Stella.
yeah, but you keep trying until you get there. So if I tell you that this is a female in her reproductive age,
Yeah, maybe like Arias-Stella, like
that's Arias-Stella reaction. So see, these are clear cells. So on
Yeah.
high power, see, these are clear cells. These are clear cells, and that's why I show you high power here, because these are clear cells. So you might say this is clear cell carcinoma. Actually, with this degree of pleomorphism and this degree of atypia, I might say this is clear cell carcinoma. And in the low power, this looks really ugly. It looks really like a cancer. It looks like clear cell cancer. But the cells are like irregularly shaped, as you mentioned. There's some kind of hobnailing, some kind of irregular arrangement of them, which look like clear cell carcinoma in a reproductive age female. It's not old age. So I might need to throw some immunos to confirm that this is not clear cell. So I will throw napsin A, and I will throw HNF1 beta, and then they will be negative. Oh, okay, Ki67 is low. Oh, okay, so this is Arias-Stella reaction then. This is due to pregnancy hormones or gestational trophoblastic disease, okay? Muhammad, very easy. You're lucky.
Okay, what was this again? This is strips. I remember the strips and clips you said.
Yeah, this is like the paper clip.
Atrophic, yeah. I think
Yeah,
it's
and this
atrophic.
is the Swiss
Swiss
cheese.
cheese, yeah.
The
Dilated.
Swiss cheese.
Mhm.
The dilated cystic gland with atrophic lining and atrophic surface epithelium. The atrophic epithelium have scant cytoplasm
Cytoplasm.
and very little, and like it's nearly as if they are monolayer of nuclei beside each other. And then you might see some endometrial glands falling off, and they are curved like paper clips.
Mhm.
That's atrophic endometrium, or what you said, inactive endometrium. It's the same. But I believe inactive, they usually call it they call it for the ovary. They rarely call inactive endometrium. They call it like inactive ovary or, yeah, but it's the same thing, potentially the same thing.
Question, can you go back to that slide? It can I know this the cystic gland stuff, it kind of looks like Nobodian cyst, but I know it's not like different location, but it's
Yeah,
kind of same.
it's different location, of course, yeah. But
Yeah.
and Nabothian cyst, if you go to high power, you'll see this secretory lining. The lining would be like endocervical lining if we go high power. But here, if you go high power, you'll see this atrophic cells, and there's no secretions there. There is no like endocervical columnar cells with this apical mucin, you know. So that's how we differentiate it from the Nabothian cyst. Next is Siham. This is in the myometrium. Very easy.
Yeah, so we see glands, endometrial glands.
The endometrial glands.
in the
If I say that this is in the myometrium, so the diagnosis would be? It would be adenomyosis.
Yes.
If we are in doubt, what do we, which stain is for this endometrial gland?
We said CD for the glands, ER.
ER. And for the stroma?
Should be CD10.
CD10. Yeah. For the stroma, CD10, and for the glands, ER. Good job. What is this, Abdurrahman?
Do you want the scientific term? Piano keys.
That's the scientific. You know why I'm focusing on this picture? Because of how much I got it in the Q-Banks. It's very boardable. Like that's why I'm bringing it three times.
You know how does it look? It looks like endocervical, not endocervical cells, like tubal epithelium in pap smears.
Well,
So-
potentially.
Yeah, I was doing cytology like 2 days ago. So
Yeah. Okay, that's it. I hope that you. I know that it's a really tough part, the benign endometrium, and we took it at the end of the day. So I hope that you enjoyed it. So try to consolidate the information by reading the notes. Read the notes, and try to look at pictures. Pictures give you experience. So I don't know if you guys have subscription to Expert Path or not. Does your
we
program?
do in GW.
Okay, good. So good for you. Then go through the pictures of Expert Path, or even some other programs give subscription to Path Primer. Path Primer.
We do as well.
You have both. Oh wow, it's a
Yeah.
you are a very rich program.
Well, don't jinx it, okay?
Yeah. So I want to ask. So do they give you any QBank subscription?
We have ACB Ostlers and we have Blue Book. I guess these are the subscriptions we have.
ASCP, and you have Osler even.
Yeah.
Oh wow, yeah. Wow.
I don't know about Path Dojo, but I don't think we have it. I mean, for
Yeah,
everyone.
but in NYU they have Path Dojo, and that's the good thing about this program. I mean, this make you save money. Path Dojo is very excellent. Although
No, I know my seniors are like we're doing Path Dojo and are doing Path Dojo, but I'm not sure if the program is
So,
providing it or it's actually they just did it.
Yeah, it's very good, but it has some like disadvantages. They don't put labels on the pictures in the explanation. Like they explain,
Oh.
they give the explanation with a picture, and they don't put any labels on the picture. They don't tell you which is which. This make it so hard and make it so tough. The experiences, the explanations also are not very comprehensive. They're just like very, very like summarized explanation, and it hurts. But very high yield. They focus on the very high yield facts. Okay, so we're good to go. We will. So then I will see you Friday. Okay, after tomorrow, because tomorrow is a crazy busy day for me. So we will meet again on Friday. We will start endometrial cancers or the tumors of the endometrium. So thank you very much and see you on Friday.
Thank you.
Thank you.